Welcome to this GammaBrief whiteboard session. Today we are going to map the main alpha-emitting tracers in nuclear medicine. We will not stay at the level of buzzwords. Instead, we will look at what each radionuclide really brings in terms of physics, radiobiology, logistics, and clinical applications. From the established standard radium-223 to emerging candidates such as actinium-225, astatine-211, lead-212, terbium-149, and thorium-227. Alpha particles are not just stronger betas. Their range in tissue is only a few cell diameters, typically less than 100 micrometers, but their linear energy transfer is extremely high, around 80 to 100 kiloelectron volts per micrometer. The relative biological effectiveness compared with beta emitters is roughly 5, creating dense clusters of double-strand DNA breaks and a high probability of clonogenic cell death, even in hypoxic or slowly proliferating tumor cells. This physical profile makes alpha emitters particularly attractive for micrometastatic disease, minimal residual disease, bone marrow involvement, or small clusters of circulating or disseminated tumor cells, situations where beta emitters may underdose individual cells. However, alpha therapy is not simply beta therapy with higher Lt. The short range, the complex decay chains, and the recoil of daughter nuclides introduce specific radiochemistry, dosimetry, and radiation safety challenges. The SECURE project was created precisely to map these issues and to define realistic recommendations for clinical translation in Europe. On this map, we will keep 7 alpha emitters in focus. Radium-223 is the only one with regulatory approval today. Actinium-225 and Bismuth-213 are powerful nanogenerators with complex decay chains. Astatine-211 and lead-212, via its daughter Bismuth-212, offer cleaner or more controllable decay schemes. Terbium-149 is an elegant but production-limited option, and thorium-227 underpins the family of targeted thorium conjugates. Radium-223 is our starting point because it is currently the only alpha emitter approved in routine practice. Chemically, radium behaves like calcium and targets areas of increased osteoblastic activity. Clinically, radium-223 dichloride is used in metastatic castration-resistant prostate cancer with symptomatic bone metastases and no major visceral burden. Its dosimetry at bone surfaces and bone marrow is relatively well characterized, with acceptable hematological toxicity when used on-label. The SECURE review uses radium-223 as a proof of concept that alpha therapy can be developed, approved, and reimbursed, but also as a reminder that translating alpha physics into real-world benefit requires long-term safety data, large-scale production, and very robust quality control. Actinium-225 is the rising star of targeted alpha therapy. With a half-life of about 10 days, it behaves as a nanogenerator. Each parent nucleus produces a cascade of alpha and beta emissions through multiple daughters. When labeled to PSMA ligands or somatostatin analogs, Actinium-225 shows high response rates even in patients who have progressed after lutetium-177 therapies, suggesting that alpha therapy can overcome some mechanisms of resistance to beta emitters. However, the same decay chain that provides this high-Let payload also creates a major safety and dosimetry challenge. The recoil energy after alpha emission is far above any chemical bond, so daughter nuclides such as francium-221 or bismuth-213 can be ejected from the collider and redistribute, in particular to the kidneys. This breaks the simple link between injected activity and dose delivered to the tumor and increases the risk of off-target toxicity. On top of that, actinium-225 supply remains limited. Most production relies on thorium-229 stock or high-energy accelerator routes. For alpha therapy to scale beyond niche, industrial production and robust chelation chemistry for the entire decay chain are essential. Bismuth-213 is a short-lived alpha emitter with a half-life of around 46 minutes. Its short physical half-life makes it particularly suitable for fast-targeting vectors, such as small antibodies, peptides, or nanobodies with rapid tumor uptake and clearance from blood. Early clinical experiences in hematological malignancies and solid tumors suggest meaningful efficacy with manageable toxicity when the vector internalizes quickly. The limiting factor for Bismuth-213 is logistics, on-site generators, narrow radiolabeling windows, and the need for highly streamlined radiopharmacy. For most centers, Bismuth-213 will only be feasible in the context of controlled trials or highly specialized programs, astatine-211 is often described as a clean alpha emitter because each decay produces a single alpha particle without a complex cascade of daughters. This simplifies dosimetry and quality control. As a halogen, astatine can be incorporated into aromatic rings, enabling a range of small molecules and antibodies, preclinical work in brain tumors, colorectal cancer, and more recently FAPI-based ligands shows highly promising tumor control. Lead-212, with its daughter bismuth-212, behaves as an in vivo generator of alpha emissions. Lead-212 itself is a beta emitter, but it decays to bismuth-212, which provides the alpha payload. From a practical standpoint, lead-212 can be produced and distributed as a generator system, then labeled to peptides or antibodies on site. Imaging with lead-203 or lead-212 SPECT enables a true theranostic approach with quantitative dosimetry. Terbium. 149 is an elegant isotope because it belongs to a so-called quadruplet. Terbium isotopes can support PET, SPECT, beta, and alpha therapy with very similar chemistry. Terbium 149 specifically is an alpha emitter with PET photons, making it ideal in principle for image-guided alpha therapy. However, its production currently requires complex accelerator settings, and clinical data remains scarce. Thorium-227 underpins the family of targeted thorium conjugates, or TTCs. In these agents, thorium-227 is chelated to a monoclonal antibody against targets such as HER2, PSMA, mesothelin, or CD22. Preclinical models show impressive tumor regression and durable responses. Phase 1 trials have reported acceptable safety profiles and objective responses, especially with CD22-targeted TTCs in hematological malignancies. Across all these tracers, the secure review insists on 4 cross-cutting challenges. First, production and supply. Without reliable large-scale production of parent isotopes, alpha therapy will remain restricted to a few academic centers. Second, daughter recoil and redistribution. For cascades like actinium-225 or thorium-227, micro-dosimetry must take into account where the daughters actually go, not just where the parent was bound. Third, micro-dosimetry itself. Because the alpha path length is measured in tens of micrometers, organ average doses are not sufficient. We need realistic microscale models of bone surfaces, glomeruli, tumor spheroids, and bone marrow niches to interpret toxicity and efficacy. Fourth, clinical trial standardization. Harmonized dosimetry, common response criteria, and structured reporting are essential if we want to compare isotopes and move from phase Y signals to phase 3 standards of care. In summary, radium-223 proves that alpha therapy can be translated into a reimbursed standard for a very specific indication. The next wave, actinium, astatine, lead-212, terbium, and thorium, is expanding the toolbox towards PSMA, neuroendocrine, and other targets. For nuclear medicine teams, the key questions are no longer only, does alpha work, but for which patients, with which isotope, and at what dosimetric cost for bone marrow and kidneys. For GammaBrief, the take-home message is simple. Alpha tracers are moving from experimental posters to structured clinical programs, but their success will depend as much on radiochemistry, production, and dosimetry as on clever targeting. If we address these 4 pillars, the question will no longer be whether alpha therapy has a place, but how broadly we can deploy it in routine nuclear medicine.